Thank you, Ankit. So, good afternoon, everybody. A very, very warm welcome on this winter afternoon to everybody who is interested in learning and interacting more about insulin. Dr. Banshi Sabu sir, who's our program director, and Dr. Vipul Chawda, who's our program coordinator today. Dr. Banshi Sabu sir needs no introduction, but sir is the chairman and chief diabetologist for Diacare, Diabetes Care and Hormone Clinic. He is the immediate past president for RSSDI, president for AERO, honorary secretary for Diabetes India, and has numerous work, to his credit. He is an academician, he's a clinician, he's a researcher, and he's a mentor to almost all the faculties present here today on this iSchool platform. With that, I'm going to request Dr. Banshi Sabu sir, whose brainchild of iSchool is here to make, insulinization an actual trend. With that, Banshi sir, can I request you to please introduce iSchool?
Yes. Thank you, Durvi. Thanks for kind words. So first of all, I would like to tell you that how iSchool was started. So I congratulate all the participants. I welcome them. And I also thank all the faculty members. But iSchool we started before 2.5 years. As we know that most of type 2 diabetic patients in our country, almost 2/3 of them are uncontrolled. And it is the insulin initiation is actually delayed. It is delayed not for few weeks or few months. It is like few years are delayed in their therapy. So insulin is not the choice neither by the patients nor by the doctors themselves. iSchool is an initiative of Sanofi. Actually, Diacare is supporting it. And we thought of that we should have an iSchool almost in across the country, in each region, from each city, from each state. And then Sanofi agreed that, yes, sir, we will have the iSchool everywhere, because it was planned in 2019 when we thought of that we will have a physically, we will be inviting some 20-30 doctors who are actually not prescribing the insulin. How we started, long back when I was giving one talk in one of our medical college, which is newly formed in Ahmedabad only. And I just asked the doctors who were there, many of them were actually faculty member, and I just asked them in OPD basis how you start the insulin. And most of the consultant, even they are faculty of that medical college, they were telling hardly they start the patients on an outdoor patient department. They normally start the patients when the sugar is very high and they get admitted. That is the time when they start the insulin. So it was to my surprise that in 2016, this was the they told me, and the Glargine is available since last almost 20 years to our country, which is so easy, to start with the patients on a basal insulin. Our country's maximum number of patients, they are started with a premix insulin, again, without monitoring, more chances of hypoglycemia. I am the one who is starting most of our patients on a basal insulin, and I am very much for basal insulin. I have done multiple times debates also why basal should be the first choice. And now it had come in the guideline also. Since last so many years, we know that insulin is to be started with the basal insulin. The premix is still a choice for many of our clinicians. That is not the point of debate today. So then I asked the Sanofi that, most of the people are not actually starting the insulin on an outdoor patient department, at least physicians, not the diabetologists, and let us start a program which is dedicated primarily for insulin, how it should be initiated and how it should be intensified for primary care physician. It was planned in a physical format where in each city or almost in each state, we will have 1 or 2 iSchool, and where we'll be inviting these primary care physicians or consultants, some of them who are not very, comfortable to start the patients on insulin on outdoor patient department. We will be inviting them. We have done the first program in 2018 with 30 doctors were there. You know that, Dhruvi, you were there part of it. We have done with the residential program. These doctors were staying also. And then it was started on a Saturday afternoon. On Sunday, again, we have the program remain for half a day. So similar type of thing which we have done in 18 and 19. But then 2020, it is because of COVID. So now iSchool become much, bigger. because now we can invite more number of doctors on this platform. It is no more restricted for 30 or 40 doctors who can come physically, to whom we can give them a stay also. Yes, there is always a more charm in physical program, but on a digital platform, we can reach out to thousands of doctors. We can reach out to the rural physicians. We can reach out to the doctors who can't come and stay with us for 2 days. And Saturday and Sunday, this program, now we thought of we will be doing every 3 months or 6 months. And every time we will try to get hundreds of the doctors. This time we are primarily doing it for Western region of our country, from Maharashtra, Gujarat, and Rajasthan. Primarily, we will be inviting the doctors and they are attending. And I'm very happy to tell you that more than thousands of the doctors who are registered for the meeting this time. I'm not sure how many of them will see it live. But one more big thing which we are doing this time, it will be live streamed on a DocTube. DocTube is a baby of Dr. Rakesh Parikh, so I congratulate him. DocTube is a new initiative where all the lectures which are already, happen on a different platform of last 2 years or 3 years, they all will be there on this DocTube. It's like a YouTube for the doctors. It will not be restricted only in medicine or diabetes or endocrinology, but in all subspecialty. You can just search if you want to know about any subject, about any speaker. It will not be restricted only to the national speaker. Even we will be having a lot of talk from the international speaker also on DocTube. So this time, this iSchool, where we are having, it will be live streamed on DocTube also. And later on, so somebody wants to listen, any expert related to insulin therapy or this iSchool, any lecture, they can listen on this DocTube platform also. So with these few words, I think iSchool is really neat. It is required more for primary care physicians. We still have patients which is less than 10% of our type 2 diabetic patients are actually on insulin therapy. If you see the Western data, it is almost like 20 to 25% of the patients are on insulin therapy. We always debate when we should start the insulin therapy, whether it's a triple drug or a quadruple or even more than 4 drugs. Patients should be there and then they should be started on insulin. But that debate will continue. We need not to talk about that, but I think that insulin should be started at the appropriate time. If I'm not saying it's early initiation of insulin, but the appropriate time is very, very important. And what should be the appropriate time, that we will discuss in next 2 days. With this, I welcome some of my close friends. We have Dr. Rakesh, Dr. Amit, Dr. Pratap Jetwani. They will be starting this talk. So now over to Durvi to introduce our chairperson and then to start with first talk. Thank you.
Thank you, Banshi sir. Thank you for a wonderful introduction to our iSchool. And since we are celebrating 100 years of insulin now, it is quite appropriate that, we spread insulinization at the appropriate time for the appropriate candidates. With that, I again welcome all the candidates, and we have a good number, sir, to our iSchool on virtually. Our first 2 chairpersons for the first session of iSchool are very, very dynamic, 2 upcoming young diabetologists, Dr. Tarjani Vyas, who is currently training under Dr. Banshi Sabu sir as a diabetologist, and Dr. Kamudini Chinamsetti, if I'm pronouncing your name correct. She is an MD, General Medicine, and again, she's our RSSDI student and an upcoming diabetologist. Over to you, girls.
Thank you, Dhruvi ma'am. Thank you, sir. Our first speaker is Dr. Rakesh Parikh, sir. Sir is going to speak on pharmacology of insulin. Sir is a consultant diabetologist based in Jaipur. He's also a fellow of American College of Endocrinologists, Royal College of Physicians and Surgeons, Glasgow. He's a life member of RSSDI, DFSI, Diabetes India, DIPSI, and IMF. He is the principal investigator on several phase 3 global clinical drug trials and has over 50 publications, including textbook chapters. He is also a reviewer and editorial board of several journals. I welcome you, sir, and we can begin with the topic, pharmacology of insulin.
Thank you. Thank you, Dr. Kamudi, for the nice introduction. And thank you, Dr. Banshi sir and Dr. Vipul Chawda for inviting me. on iSchool. Are my slides visible?
Yes, sir, they are visible.
Okay, thank you, thank you. So it's very appropriate to have the iSchool symposium specifically dedicated to insulin on a day which is coinciding with the 100 years of insulin. And so let's start our presentation, and I will talk only on insulin pharmacology. I'm sure there are different lectures on different aspects of insulin therapy. Following me, my friend Dr. Amit will be talking on the different regimes of insulin. So I'll not go into that part. I'll just focus on the basic pharmacology to start with. Okay, so let's start the presentation by remembering Leonard Thompson, who was the first person to receive insulin. He was given insulin for the first time on 11th January of 1922. And that did not go very well because that insulin was not able to control his glucose levels or ketosis. Again, the second attempt was made after 12 days with some purifications in the insulin. And that was the first successful attempt to use insulin in a human being. That was on 23rd Jan 1922. So tomorrow we'll be completing exactly 100 years of that particular day. And this was the first vial of insulin which was used for treating him. And this definitely this was a historic moment which was globally covered by all the newspapers, because that was a landmark discovery in the treatment of patients of type 1 diabetes who never had any other option earlier. They were just left to die, and this changed that completely. And after the discovery of insulin, millions of lives have been saved just by using insulin injection. So from 1922 to 2022, in last 100 years, there have been several developments in the field of insulin. We'll touch upon a few of those which are related to pharmacology of insulin in the next few slides. So to start with, this is the insulin, which is the peptide hormone. And as we all know, it has got two chains, A chain and B chain. It's a 51 amino acid peptide, and it's secreted from the beta cells of pancreas. And these two chains, A chain and B chain, they are bound to each other by the two disulfide bonds as shown in the figure. Now, the insulin is actually produced as pre-proinsulin in the body, and then when it goes to Golgi apparatus and the insulin vesicles, it is converted to proinsulin. So proinsulin is basically insulin plus C chain. So proinsulin has A, B, and the third chain, which is a C chain, which is connecting A and B. And when the insulin is released from the beta cells, at that time, the C chain is liberated, and along with every molecule of insulin, you have C chain in equimolar proportion, which is released in the body. So the insulin secretion, it happens with the beta cells, and the mechanism is that the beta cells, they are sensitive to glucose levels. There are some other stimulants as well, like arginine and sulfonylureas. But when the blood glucose levels go above 100 milligram per deciliter, at that time the glucose enters the GLUT2 receptors of the beta cells. The glucose receptors in the other parts of body are GLUT4 receptors. This is GLUT2 receptor. So the glucose enters the beta cell. There is glycolysis, and in that process, ATPs are generated. Because of the rise in the level of ATPs, there is the potassium channels, they get activated, opened, and then there is depolarization of the cell. Calcium enters the cell, and that leads to exocytosis of insulin. So this is the normal process by which insulin is secreted in the body whenever the glucose levels go above 100 milligram per deciliter. If the glucose levels are below 90, then there is no insulin secretion. Now, once the insulin is secreted from the beta cells, it reaches the various parts of the body through blood. And then at the cellular level, the mechanism is that insulin binds to its receptors, the alpha subunit of the receptors, and that leads to different effects. So there are different signaling pathways for the different actions of insulin that we all are aware of. But then the important one is that as soon as the insulin binds to the alpha subunit of the receptor, the GLUT4 vesicles, they are transported to the cell membrane, and that is how you have GLUT4 receptors on the cell membrane, and then glucose enters the cell. So this is how the insulin is required for uptake of glucose by the different cells. In addition to this, then the different signaling pathways are responsible for the different actions of insulin, like the protein synthesis, glycogen synthesis, cell growth, and so on. Now we are again aware of the different effects of insulin. The effect when it is available in sufficient amounts in the body, it has got anabolic effects on carbohydrates, lipids, as well as on proteins. So it leads to glycogenesis, glycolysis, then glucose transport in the peripheral tissues, glycerol and triglycerides are synthesized, protein synthesis and amino acid uptake happens when the insulin is available in the sufficient amounts. But if there is deficiency of insulin, then there are catabolic effects, which are just reversal of this: glycogenolysis, gluconeogenesis, lipolysis, ketogenesis, and protein degradation. Now, the insulin, which is endogenously produced in the body, is produced from the pancreas, and so it goes to liver first through the portal vein. So there is around 40 to 50% of insulin is actually degraded at the level of liver before it enters the systemic circulation. So liver is one of the sources of metabolism of insulin. And the second important organ where the metabolism happens is kidneys. So kidneys are responsible for around 30 to 70% of metabolism of insulin, the endogenous insulin. The exogenous insulin is directly going to the kidneys for metabolism, and the insulin molecules which enter inside the cell, then they are lipolyzed they are lysed with the different enzymes, and that is how their metabolism happens. Now, the insulin secretion, again, in normal physiology, the insulin is secreted in two phases, the first phase and the second phase. So the first phase is immediate response of insulin to the rising levels of blood glucose, and that suppresses the hepatic glucose output. It restricts the PPG levels, and it induces the phase 2 release of insulin. And then the phase 2 is, though it's not, the peak is little, lesser than the phase 1, but it is sustained. Now, in type 2 patients, this phase 1 of insulin response is blunted or is not happening, and the phase 2, second phase response is also just 50% of which is there in the physiologically in the normal people. Now, physiologically, as we just saw earlier, the insulin requirement is of two types. One is the basal requirement, that is a minimum level of insulin that is required in the basal state. And then whenever the patient takes any meals, you need to have a bolus insulin shot to cover the requirement of insulin. So this is the requirement of insulin, and that is what is taken care of with the different insulin preparations that are available. So starting from the short-acting regular insulin and the intermediate-acting insulin, which were available for a pretty long time, after which we had the rapid-acting analogs and the long-acting and ultra-long-acting analogs. We'll discuss about these in the next few slides. So this is the regular insulin, which is short-acting insulin, as we discussed earlier. And earlier, we were using animal sources of insulin. When we were students at that time, porcine and bovine insulins were being used. Recombinant insulin was just introduced. Recombinant human insulin was just introduced. And gradually, the animal insulins are now out of market, and we are all using the recombinant human regular insulin. So for a long period, the people only had option of regular insulin. There was no basal insulin at that time. And then the people of patients with type 1 diabetes, they were given regular or frequent doses of regular insulin to maintain their blood glucose levels. The major breakthrough happened in 1936 when it was discovered that by adding some basic proteins like protamine, we can prolong the duration of action of insulin. And that is what was Nph insulin. So this Nph insulin was then commercially available, I think, around in 1945 or 46. And this was the first intermediate acting insulin where we were able to prolong the duration of action of insulin. At the same time, it was observed that by changing the zinc concentration in the insulin preparation, you can change the duration of action of insulin. And with different proportions of zinc and insulin, different lente preparations were available. So ultra lente, semi lente, these were the preparations which were available: lente, ultra lente, and semi lente. That they were available for a brief period, and after that, again, they are not available in the market now. So by this time, we had two different insulins, one regular insulin and one Nph insulin. And this is what we used to use for a pretty long time. During those days, we were mixing these insulins manually, regular and Nph. We used to mix them depending on the requirement of the patient. So Nph insulin is the insoluble intermediate acting insulin, and it offers a sustained release of insulin over a period of time, something around 10 to 12 hours. And In the type 2 patients, we usually start with a dose of around 0.4 to 1 units per kg body per kg per day sub-Q. And in type 1 patients, in type 1 patients, that is the dose. And in type 2 patients, you will require a lower dose, that is 0.1 to 0.2 units per kg per day. So this was the most widely used form of intermediate acting insulin. So these were the two insulins. Nph became available in 1946, and they were earlier sourced from the animals, and now we have the recombinant human insulins. After that, in around 1990, we started getting the insulin analogs, and the first ones were the rapid acting analogs of insulin. And then in 2000s, we started having with the basal insulin analogs. So we'll discuss about these two in the next few slides. Now, the rapid acting insulin analogs, basically, we have three different options: insulin lispro, insulin aspart, and insulin glulysin. The mechanism by which the action of insulin is made rapid is such that the insulin preparations, they do not remain in hexameric form for a long time. Like in the regular insulin, it remains in hexameric form, and the insulin monomers are released gradually from it. So in the rapid acting analogs, the amino acid sequences are modified a little bit so that there is not a tendency to remain in hexameric form, and these insulins immediately release the monomeric forms. That is how the duration of action is modified, and they become the rapid acting insulins. So lispro, aspart, and glulysin, as you can see, their names are actually also derived from the changes in the amino acid sequence that happen in the insulin molecule. So in lispro, the change is at the 28 and 29, which is for lysine and proline. Similarly, aspart and glulysin. And just by changing these amino acid sequences, we were able to modify the duration of action or action of onset of these insulins. Now we have the another one, which is a faster acting, ultra fast acting insulin, which is Vyas. So this is basically just insulin aspart, but in it they have added vitamin B3 and arginine to make the initial absorption faster and to stabilize the formulation. So this is just aspart, but it has got a little faster action compared to the aspart. Now, in the long-acting insulins, we have the first generation long-acting insulins like insulin glargine and insulin detemir, and then we have the ultra-long-acting insulins, which are insulin glargine 300 and insulin degludec. Now, as we discussed earlier, in the Nph insulin, which is the intermediate-acting insulin, the duration of action is prolonged by adding the protamine, which is a basic protein. And in glargine, whether it is 100 or U300, the basic mechanism by which the duration is prolonged is that the glargine is available in acidic form or at acidic pH. It is dispensed at acidic pH, but as soon as that insulin is injected, then because the body's pH is around 7.4, so at that pH it gets crystallized, or it gets precipitated, and from those precipitates the insulin is gradually released. While in the other two long-acting insulins, that is detemir and degludec, there is a acyl chain which is added to the insulin molecule to prolong the duration of action. Now, this is about detemir. So in detemir, they have added a 14-carbon fatty acid chain to the insulin molecule, and by doing so, they have the insulin basically has a protraction. So the insulin binds with albumin in the blood, and in the subcutaneous space, it forms precipitates, and from those places, the insulin is gradually released, and that is how the prolongation in the duration of action is achieved. While in glargine, they have made certain changes in the amino acid sequence again, and by doing so, this insulin basically remains crystalline or clear at acidic pH of 4, and once it is injected, then at the physiology, the pH of 7.4, the glargine precipitates, and the precipitates are formed, and from those precipitates, the insulin is released gradually. That is how the duration of action is prolonged. Now, in U300, the mechanism remains same, just that it is more concentrated, and that is why the precipitates which are formed after injecting U300 glargine are smaller in size, and they have a smaller surface area, and that is why the release of insulin is further prolonged, and that is how they were able to achieve even prolonged action of duration of action. In degludec, it is basically injected in the dihexamer form. So the hexamers of insulin, they are attached to each other, and in presence of phenol, they form a multi-hexamer chain. So the dihexamers are attached to each other, and that is how they form a chain, and in the body after injection, of course. And then from that chain, the insulin hexamers are released from each end of the chain, and that is how you get a slowly releasing pattern of insulin, and that is how this actually achieves something very close to the basal requirement of insulin that we have. So to summarize these different insulins that we have available now, the first insulin to be introduced was the short-acting insulin, which had the duration of action. The onset was at 30 minutes, the peak time of 2 to 3 hours, and the duration of 6 to 8 hours. Then we had intermediate-acting insulin. Then rapid-acting insulin were introduced for taking care of the basal requirement, and then long-acting insulin and ultra-long-acting insulin, as shown in the table. Among the ultra-long-acting insulins, you have Degludec, which has a duration of action which can last up to around 42 hours, and that is how it gives something very close to the basal requirement of insulin. And to conclude my presentation, the last slide, in addition to these two, we have the premix insulins. So we have the biphasic human insulin, in which the regular insulin and Nph insulin is mixed in a fixed proportion, that is 30-70 or 50-50. Then we have the biphasic analog insulins, in which the insulin analogues are mixed in a particular ratio. And then we have the co-formulation, in which the soluble insulin aspart is mixed with soluble insulin degludec. And these three options are available commercially among the premix insulins. So at the end, let us all thank the innovators of insulin, Mr. Banting, Mr. MacLeod, Best, and Colib. So these are the people who, with their discovery of insulin exactly 100 years back, saved so many lives. And so let's all be thankful to them. Thank you.
Thank you so much, sir. Thank you so much, sir. That was a very detailed and lovely lecture. We'll take the questions at the end of the session. We'll now introduce Dr. Amit Gupta, sir. He'll be speaking on insulin regimen types, benefits, and challenges. He's the director of the Diabetes Center, Noida, member of Advisory Board, American Diabetes Association, National Executive Council member of RSSDI, Joint Secretary Diabetes India, Advisory Council member ACP India Chapter, RSSDI Defeat Diabetes Media Task Force member, Joint Secretary UPDA, reviewer in endocrine practice, Diacare Awards for leading and most successful diabetes campaign of Defeat Diabetes 2021, Times of India Health Icon Award 2021, Diabetes Excellence Award 2021, National Health Award, Diabetes Awareness Initiative Award, Investigator of the Year Award in 2019, 18, and 17.
Thank you, Dr.
Padmakar Tripathi Young Scientist Award. A lot of achievements.
For the detailed and very kind.
Over to you, sir.
Thank you so much, and I must congratulate for this initiative. And Dr. Rakesh has given a very good overview of pharmacology of insulin. And now I will be talking on insulin regimens, type, benefits, and the challenges. Is my screen visible to everyone?
Yes, sir.
So after this, the learning objective of this talk is that we want to understand what are the common challenges which are encountered during the initiation of the insulin therapy. At the same time, we want to understand what are the different types of regimens which are available, like types, benefits, and challenges associated with each one of them. Barrier to insulin therapy in type 2 diabetes is a very, very very important topic. And I think the barrier exists from the patient side as well as from the physician side. And these are the challenges which we often face while initiating somebody on insulin in clinical practice. There is a limited resources, whether it comes to management of diabetes in a non-specialist setting. The less educated patient population and poor adherence and delayed initiation of the basal insulin is often there. There is also limited accessibility to current basal insulin options, insufficient insulin dose titration, and it is not just the initiation, even the titration doesn't happen, and low treatment persistence and early discontinuation of the insulin therapy. So the patient want to listen to a doctor who says that I will stop your insulin, or I will discontinue your insulin, or I will stop your insulin. So doctor also do like that. The patient is also more inclined to something reduction of the insulin doses or stopping of the insulin therapy, which is not correct. So in order to achieve proper diabetes control, it is very, very important to initiate insulin timely. Optimization of the dose is equally important, and we must ensure that the patient adheres to the therapy to get the glycemic benefit. The key barriers, as already been seen, in Asian countries, are almost 7 out of every 10 patients will be unwilling to use insulin, even when prescribed. It may be because of the needle phobia, less education, doubts about the actual benefits of the insulin. Many people, they believe they become insulin dependence, and there are misconceptions regarding insulin as a terminal treatment, and there are perceived complexities in using insulin also. So these are the key barriers which we need to identify. And physician may also be concerned about the efficacy, safety, and flexibility of insulin therapy. Sometimes you may not be trained enough to, or may not be equipped enough to deal with the complexities of the insulin therapy. That is why the iSchool comes as a very good tool for all of us to learn more and more about the insulin therapy. Majority of the physicians, doctors, they assume that adequate glucose control is not achieved with insulin therapy, and there is a lack of familiarity with diabetes management and guidelines, leading to the delay in the initiation of the basal insulin therapy. So these are the barriers which are encountered. Many a times we don't have that much time, and the consultations are very brief. So a brief consultation is more likely to fail in convincing a patient to take the insulin. Also, unavailability of the insulin in certain regions, shortage of diabetes educators is again. And I would like to replace the term endocrinologist here, because I believe that each and every MBBS doctor in India should be able to handle the insulin prescription, should be able to guide patient on insulin. And this is what the dream of iSchool is, to achieve that. And we will continue that, our efforts to educate more and more people regarding the insulin therapy. When it comes to, these are the few other barriers. The patient will resist the insulin therapy. We often think about that. Once the patient is on insulin, the patient will require more intensive monitoring. From where the resources will come, the patient may not like to prick themselves many times a day. Again, there is a risk of hypoglycemia from the insulin therapy, which is feared most. Some people may also be apprehensive about the weight gain. Education is required, so we need to give time to educate the patient. If we are not giving time, then the patient is less likely to adhere to the insulin therapy. And we also understand that the patient resources must be taken into account, that how the patient is going to handle the insulin therapy and the various types of insulin which we are going to prescribe. So how do we address the barriers? So barriers to use insulin can only be addressed when patient and physician, they work together in tandem, along with family and the other team members. It is very important to spread the right message about the insulin on social media, through diabetes education programs, and with the help of the diabetes educators. And it is very important to enhance the soft as well as the hard skills of all the doctors who are dealing with diabetes. And drug and device barriers can be bridged by opting for the flexible, comfortable, and safe insulin regimes, as already pointed by Dr. Bansi, that it is very, very easy to put a patient on basal insulin and monitor, and it does not require that frequent monitoring also. And we should also train our team, that is the paramedical staff, diabetes educators, nurses, to facilitate insulin use. We should be relying more and more on them. Now, coming to the second section of my talk, what are the types of insulin regimens and benefit are there? So, Dr. Rakesh has already described the pharmacology of the insulin. So, we can broadly divide the insulin into rapid-acting insulin, the regular or short-acting insulin, the intermediate-acting insulin, and the long-acting insulin. The types we already know: the rapid-acting insulin like insulin glucose, Lispro, Aspart, and the faster-acting Aspart also, and now we also have faster-acting Lispro. A regular or short-acting insulin like human regular insulin is a regular or short-acting insulin. Nph is the intermediate-acting insulin, and the long-acting insulin is Glargine, Detamate, Degludec, Glargine U300, and now we have Degludec U200 is also available in some countries, not available in India. We divide this based on their action. Rapid-acting insulin onset is within 5 to 15 minutes. The peak is seen in 1 hour, and duration will last for 2 to 4 hours. While regular or short acting, the onset takes almost 30 minutes. Peak is seen in 2 to 3 hours, and it is effective for 3 to 6 hours. While intermediate acting insulin, again, the onset is 2 to 4 hours. The peak is again 4 to 12 hours, and duration of the action is again 12 to 18 hours. While long acting insulin, The duration of action is several hours, may range from 24 hours or even longer in case of certain types of insulin. So different types of insulin protocols or insulin regimes can be designed. And one is that you start a patient on once daily or twice daily intermediate or long-acting basal insulin. You put a patient on once, twice, 3 times daily premixed insulin. A basal bolus therapy in which patient takes 1 dose of the basal insulin and 3 doses of the 3 boluses at the meal time, and the mealtime rapid-acting insulin. These are the various strategies which can be employed in patients who are starting on insulin. It is important to understand that human insulin is again produced in a laboratory using recombinant DNA technology, and regular and Nph insulin produces fewer immunological reactions in patients when it is compared to the older insulins like bovine insulin, porcine insulin. So antigenicity issues, the allergic reaction issues were more with them, and it is not so with the human insulin and the insulin analogs. So how do we form insulin analogs? This has been already explained by Dr. Rakesh. Analog or modern insulins, they are formed by modifying certain changes in the insulin molecule, and they are just like soluble insulin. Analog insulins are also produced by the recombinant DNA technology. This is a slide which is showing the development of the insulin, and we know that first of all we had only the insulin which was derived from the animals, and the bovine, the porcine insulin were there. Then we had the Nph was actually the first basal insulin, you can say, intermediate acting insulin, and then we had in the pipeline glargine, detamir, followed by the other digludac and the other types of the insulin which are available there. If we compare the analog insulin versus human insulin, and these are the few points, the basal insulin analogs, if you see, they have a longer duration of action. The glycemic variability is also less. Their predictability is more, and they cause less hypoglycemia, and they have more favorable weight profile, and fewer injections are required, and improved treatment adherence is there, and patient is more satisfied with analogs. When it comes to rapid-acting insulin analogs, the advantage is that they have a faster onset and offset. They are more physiological, and you can give it, time it more conveniently with the meal. There is no need to put the patient on a waiting period. There is a less risk of hypoglycemia and greater flexibility and convenience in times of timing and administration. And again, this leads to improved treatment satisfaction, and the patient is likely to be more adhered to the therapy. So the course consideration is the main drawback when analogs are compared with the human insulin, because they are 2 to 3 times more expensive than the conventional insulins. If we look at the duration of the insulin action with once daily basal insulin regime, you will find that exact duration again depends on the type of insulin we are using. Insulin analogs may provide almost a cover of 24 hours, though cover may weaken during the last few hours of the day. And the intermediate human insulin preparations may only be active for 8 hours or more, and they have a more pronounced peak activity. So when we are using intermediate insulins like Nph, there is a greater risk of hypoglycemia, and there is a more chances of glycemic variability with the Nph. So what are the benefits of once daily basal insulin? If you put someone on once a day insulin regime and the 2-way insulin analog, the patient needs only 1 injection per day. This may overcome resistance to starting with multiple insulin injections. It may be particularly useful when a patient's blood glucose is high overnight and in the morning, especially for the fasting hypoglycemia. It is also useful for a patient who require someone else to administer their insulin. So if you give insulin to the patient and it has to be injected multiple times a day, and that has also be assisted, then it is again a barrier for the patient to take the insulin. And it may also be associated with fewer side effects than the other types of regimes. If we compare the rapid-acting insulin analogs, what are the desirable features and resulting benefits? So again, the rapid-acting insulin analogs, they have predictable time action profile, and precise dosing is something which can be achieved with them. Short duration of action, so it reduces the risk of hypoglycemia, and there is a optimal glucodynamics. Rapid onset of action again allows for reduced postprandial hyperglycemia, and they are more closer to the physiological secretion of the insulin. So there is a more convenient injection time. And hypoglycemic potency greater than the human insulin is there, but they are not immunogenic. They have a stable chemistry, and they can be mixed with long-acting insulin analogs also. This is the unmet need we have seen. So features of rapid-acting insulin analogs, if we look at the time action profile, and if we compare the insulin lispro and the human insulin regular, we will find that the human insulin regular, there is a more rapid onset and shorter duration of action with the insulin lispro, and this leads to better glycemic control and lesser risk of hypoglycemia in the postprandial state. If we compare a rapid-acting insulin analog to the regular human insulin, you will find that a rapid-acting insulin can be injected just before meal, and a waiting interval of 30 to 45 minutes is not often required. And better control post-prandial hyperglycemia we have already seen. There is a less nocturnal hypoglycemia because it peaks more in sync with the peaking of the glycemia. And there is a better HbA1c control possibility may also be there. And the better HbA1c control and less hypoglycemic episodes and the pump treatment has been seen with the rapid-acting insulins. If we see the insulin analog mixtures on glycemic profile in type 2 diabetes, mixtures can control both basal and mealtime hyperglycemia. So this is something like you have a mixture of human insulin or analog insulin in a ratio of 30 to 70 or 50 and 25 to 75. These are available. So they have a longer acting component and they have a short acting component. The short acting component will take care of the mealtime hyperglycemia, while the longer acting or the intermediate component that takes care of the basal hyperglycemia. So this is the case. There are a variety of insulin regimes which can be tailored to meet the individual need of people with diabetes. The ultimate goal is to have an insulin release profile which matches more similar to a physiological state. But at the same time, we need to understand the need of the patient. It should be based on the convenience of the patient, and the treatment option also depends what type of diabetes are you treating. If you are treating a type 1 diabetes, then the type of regime is totally, obviously will be totally different. The person's lifestyle, age, and ability to self-test blood glucose is also a very important factor, because the dose of the insulin therapy can only be decided if you test regularly, and presence of the obesity and the choice of the patient again matters a lot. So this is the premix insulin human and the analog insulin. These are the possible regimes which can be given. You can give a premix insulin injection at the breakfast, then you can give a premix injection again at the dinner. And as already explained, there is a basal component and a short acting component. And the possible regimes can be there that once daily with largest daily meal, you can give it twice daily with dinner and the breakfast, or you can even give 3 times daily with each meal. So these are the possible regimes which can be crafted out of a premixed insulin preparation. So which insulin at what time? So at initiation, most of the guidelines, they say that you start with a basal only regimen, and then you can intensify the insulin as per the need. You can go with the basal plus, then you can go for a basal bolus, or you can also go for a premix type of insulin regime. So the key takeaway from this talk is that we understand that there are barriers at the level of the patient as well as the level of the prescribers. So we need to address those barriers. We need to address the fear of the patient as well as the medical practitioners, and we want to educate more and more people so that they are comfortable with the insulin therapy, both at that from the patient point of view and from the provider point of view. So also the patient education is equally important, because patient acceptance will not increase unless or until we will educate them. And now you have to be very flexible when choosing a regime. It is always easier to put the patient on a basal insulin, and the follow-up is also very simple. If required, you can intensify the regime to that suits to the need of the patient. So with this, I would like to conclude and thank again to Dr. Bansi Sabu sir and Dr. Vipul Chavda and Dr. Dhruvi for making us part of this iSchool. Thank you so much.
Dhruvi, we have
क्या सर?
कोई क्वेश्चन है?
अभी there are no questions.
Sir, questions at the end of the session?
Yes, Tanzini, you can.
Okay. Thank you, Amit sir. Now we'll go on to our next speaker, Dr. Pratap Jethwani sir. So I would like to introduce Sir. Sir is a fellow RSSD and fellow of Diabetes India. He is the executive member of 2020. He's done MBBS, MD Medicine, and diploma from UK. He's the honorary secretary of Gujarat State Chapter of RSSDI, organizing secretary of RSSDI 2000. Past student and BA. He's a section editor, Sadico's International Textbook of Diabetes, a member of RSSDI, AAC, Endocrine Society, and he's the immediate past president of Association of Physicians of Rajkot, consultant diabetes specialist at Jethani Hospital, Rajkot, and visiting diabetes specialist at Rotary Midtown Diabetic Clinic, Rajkot. He's presented posters and participated in various state and national conferences, and is the ex-editor of Madhu Monthly Gujarati magazine for diabetes patients. Today, sir is going to speak on insulin initiation, titration, and intensification. Over to you, sir.
Thank you, Dr. Kaumudi. Let me first thank Dr. Bansi, my mentor, my guide, my brother. I think he is the reason why we all are here to educate people about insulin therapy. So he is at the forefront as far as diabetes war is concerned, not only at India, but at international level. Thank you also, Dr. Vipul, Dr. Dhruvi, and the entire DIAK team for involving me again in this edition of iSchool, an initiative by Sanofi. So let me share my screen. So today I will be speaking on insulin initiation. Hope my screen is visible.
Yes, sir, it is now.
So today I will be speaking on insulin initiation, titration, and intensification. Is my screen visible?
Yes, it is.
Sir, yes, sir.
Yes, sir,
Okay.
slides.
Okay, fine. So this will be the flow chart of my presentation. So we all know that timely insulin initiation is very much important in people with type 2 diabetes because it improves beta cell function, it improves glycemic control, reduces risk of development of complications because of improved glycemic control. It has got anti-inflammatory effects and it improves quality of life. But whenever we say insulin, immediately there is a terminology which is being coined by Dr. Sanjay Kalra, that insulin distress, which is an emotional response to the idea of using or initiating insulin due to perceived incompetency to manage with insulin therapy requirements. And this insulin distress can result in extreme apprehension, dejection, or discomfort, and it can be either acute, subacute, or it can be chronic, or it can relapse even in people who are on insulin therapy, and then because of some event it may relapse also. And because of this insulin distress, many a times physicians, they are not able to convince their patient for timely initiation of insulin therapy. And there are a lot of patient related factors and physician related factors. I think Dr. Bansi will highlight all these things in his talk on barriers to insulin therapy, and we need to have a step-by-step approach so that we can convince our patients to start insulin therapy. Now, once we convince our patients to start insulin therapy, which insulin should be considered for insulin initiation? That is the part of my talk. So these are the factors which we should consider before initiating insulin therapy, starting from age, daily schedule of the patient, what is level of physical activity of the patient, eating habits or dietary habits, social situation and cultural risk factors, they also play an important role while deciding insulin therapy. Diabetes related complications, comorbidities, if they are present or not, they also influence the choice of insulin therapy, and preference for self-management and life expectancy. These are few factors which one should keep in mind when choosing an insulin therapy for a given patient. Also, it is very much important to involve patient in a conversation that is being termed as insulin conversation. And these are 4 important components, starting with patient's lifestyle and daily routine, then discussing them about talking with them about their concerns about insulin therapy, then setting short and long-term goals, and then asking them their problems, and then giving them specific solutions to overcome those problems. So the right insulin conversation at the right time, it helps healthcare professionals to obtain patient supports in the successful initiation and maintenance of insulin therapy. And these are the 5 steps that first you discover how the patient feels about insulin, explain and educate them about insulin therapy and its advantages, problem solve with the patient, then develop a plan together, and then set expectations, and then keep with the plan and modify plan depending on the circumstances. So the age-old question, which insulin is to be started, basal or premix? I think nowadays we have got a very good evidence base to support that basal is the way to start insulin therapy in type 2 diabetic patients who are not able to maintain glycemic control with optimal dose of 3 or more oral anti-diabetic agents, because it is simple, it has got lower risk of hypoglycemia, it is very easy to administer, very easy to titrate. Premix is somewhat complex, more amount of insulin is required, more chances of weight gain, more chances of hypoglycemia, and nowadays that's why the premix is generally not is the initial insulin in type 2 diabetic patients, because in premix it has to have a predictable lifestyle. If the patient is having flexible lifestyle, not following a meal pattern in a desired time intervals, then the risk of hypoglycemia is very high when you use premix twice daily in this category of patients. Because of higher total daily insulin dose requirement, because of the component of the regular insulin there in the premix, there is a greater risk of hypoglycemia, there is a greater risk of snacking to avoid hypoglycemia, and therefore there is a greater risk of weight gain with premix insulin. And it is very difficult to titrate the premix twice daily by patients themselves, depending on the self-monitoring blood sugar pattern. So it is very, very complex to follow in a day-to-day situation for a patient. Whereas fasting, basal is the insulin which fixes fasting first. And this is the concept nowadays, that if you fix that fasting hyperglycemia, the fasting plasma glucose will come in the range, and most of the time, in around 50 to 60% of the people, the postprandial glucose also will come in the range because of the reduction in the fasting plasma glucose. And that is the reason, and that is the rationale of starting basal insulin in type 2 diabetic patients who are failing on oral anti-diabetic agents. And that's why it is being recommended by almost all the organizations across the globe, be it IDF, ADA, American Association of Clinical Endocrinology, NICE, even our own RSSDI, Endocrine Society of India or Endocrine Society of US, almost everybody, they recommend basal insulin as the preferred insulin to start in type 2 diabetic patients. In 2012, we all know that ADA and ESD, they were giving option of either basal or premix depending on the circumstances, but now they have shifted that first to start in type 2 diabetes, the first insulin to start is the basal insulin. And basal insulin, as I have already highlighted, it not only normalizes fasting plasma glucose, but it also reduces postprandial glycemic excursions. This is data from the multicentric study where people who were on basal insulin, they were able to maintain both their fasting and postprandial in a range as compared to the control group where both fasting and postprandial, they were out of the range. Also, the sub-study of Origin trial, it says that the strict control of fasting plasma glucose with insulin glargine is effective in controlling postprandial glycemic excursions and not associated with a significantly increased risk of hypoglycemia. You should keep in mind that this study was carried out in people who were either having pre-diabetes or diabetes, early diabetes with HbA1c, baseline HbA1c of around 7. And at that point of time also, the basal insulin worked, and it provided better fasting as well as postprandial glycemic control. Now, how to start with basal insulin? This is the Be Smart recommendations, and I think all of you should go through these recommendations. They've given a very good 7 vital T's for basal insulin use in type 2 diabetes. That is 7 T concepts. So first T is treatment initiation. So treatment initiation is with basal insulin only, because it provides good glycemic control so that complications can be reduced or prevented. Second T is timing of administration. Whenever you start basal insulin, particularly the routine basal insulin, not ultra long acting basal insulin like glargine 300 or degludec, but the routine glargine 100, then it should be injected at the same time every day. Most of the time it is evening, but one may start with morning dose also, but the time should be same every day. Whenever you prescribe basal insulin, you should write down time, not before dinner, after dinner, or at bedtime. You should write down in a prescription specific time that insulin glargine 10 units at 10 p.m., 9 p.m., 8 p.m., and you have to counsel your patients that this insulin is to be taken same time every day. That is the most important aspect whenever you are starting a basal insulin. Technique of administration we all know, and I think after me, Dr. Jimit will discuss about insulin injection techniques and various other issues related to insulin therapy. Transportation and storage, I think also Jimit will touch upon, but open or in-use insulin vials or cartridges or pens may be kept at a room temperature for 28 days unless the room temperature is 37 degree or below 2 degree, above 37 degree or below 2 degrees centigrade. Necessary temperatures should be maintained during transportation. Then fifth T is tablets. Whenever you are starting your patient on a basal insulin, unless and until the HbA1c is near 7, you may continue with all the things which are there, oral drugs which you are continuing with. When the patient's HbA1c is near 7 and you are putting them on a basal insulin, I think you are justified to reduce the dose of sulfonylureas because the patient may land with hypoglycemia. Otherwise, all other drugs you can continue with when the patient is on a basal insulin therapy. Then comes targets for titration, that is 6th T. So titration of insulin dose should be based upon fasting plasma glucose, and that we will see in subsequent slides. And last is tools for monitoring and troubleshooting. Basal insulins, they are associated with very low risk of hypoglycemia, so they do not require very cumbersome monitoring schedule. Monitoring fasting and one post meal every 4 or 5th day suffices. Initially, for titration, you may require much more frequent monitoring. Once the patient is on a stable dose, with good glycemic control, they may monitor fasting and post meal every 3rd or 4th day or twice a week, and that will be sufficient for them to reach the good glycemic control. Now, you have started with basal insulin. Now, how will you proceed with titration? And if required, how will you do intensification? That is the second part of my talk. So titration is most important because whenever you start basal insulin in your patients, you have to counsel them that this is the dose we are starting, and we will require a titration of the dose to reach our target fasting plasma glucose level. Otherwise, the patient will keep on taking same dose, will not turn up for follow-up, and at the end of 3 months, when the patient will come, you check their HbA1c, it will be 7, fasting will be very high, and the patient has not utilized that 3-month time period to titrate insulin properly and to reach the target fasting plasma glucose. Dose titration is generally patient-specific. Individualization is required. Adequate titration either by physicians or by patient. Both way you can do. You can even use web-based tools, technology to support the titration schedule to help the patient to titrate basal insulin therapy to reach fasting plasma glucose. Even my dose coach, that application is available, and you can tell your patients to install that application, and you can give them a schedule data. That application will help them to titrate basal insulin dose to reach the target fasting plasma glucose. So generally titration, either you have to start with 10 units per day, or depending on body weight and baseline A1C, you may start with 0.2 or 0.3 units per kg body weight. Every 3 to 4 days, every 2 to 3 days, you have to monitor fasting plasma glucose, and depending on that fasting plasma glucose, you have to titrate insulin either upwards or downwards. And if there is a hypoglycemia, then you do not need to increase the dose. You may require reduction in the basal insulin dose. So depending on body weight and HbA1c, you may decide the starting dose of insulin. Many people, they prefer 10 units approach. Otherwise, you may straightway start if the patient's HbA1c is more than 8 and patient's body weight is around 100 kg. You may start at 0.3 units per kg body weight, that is 30 units straightway, or otherwise you may start with 20 units and then you may titrate depending on the fasting plasma blood glucose levels. Both things are perfect. Whatever way is suitable to you and your patient, you may start that formula, you may adapt that formula and start that much units for a given patient. So titration algorithms are defined by various organizations. They suggest different kind of titration algorithms, but generally it is 2 units every 3 to 5 days till the fasting plasma glucose is reached. And whenever there is hypoglycemia, you have to reduce the dose by 10 to 20%. That is what the suggestion by ADA and American Association of Clinical Endocrinology. If we go by the Be Smart recommendations, then this is pretty simple recommendations. If it is less than 80 fasting, then you have to reduce dose by -2. If the fasting is less than 70, then you have to reduce dose by 20%. 80 to 130, same dose is to be continued. 131 to 160, increase dose by 2 units. 161 to 180, increase dose by 4 units. And when it is fasting is more than 180, then increase dose by 8 units. So this is the very simple way of educating your patients that how they can titrate basal insulin according to the fasting plasma glucose on SMBG schedule. You have to empower patients to self-titrate basal insulin. That is the beauty of this molecule, that patients can do everything by themselves. They can come back in case of any difficulty or problem. You can give them your number or diabetes educator's number, and then they can guide them in case of a difficulty or any problem. Patients' ability and motivation should be considered before telling them for self-titration. Titration algorithm should be simple, safe, and effective, can be individualized depending on the patient. Key information regarding titration should be reinforced. Every time patient comes, again, educate them, ask them how they are doing titration, give them some kind of hypothetical situations that suppose your fasting comes this, what will you do? Will you increase by 2 units? Will you increase by 4 units? Or will you decrease? Or will you continue same dose? That way you can educate your patients. And if the patient is unable to calculate dose, simplified algorithm, just simple increase by 2 units or decrease by 2 units, that also is good enough if the patient is not able to follow a complex algorithm of +2, +4, +8, depending on the blood sugar value. So simply telling them, if your fasting is more than 130, increase your dose by 2 units. If your fasting is less than 80, decrease your dose by 2 units. So that is the most simplified algorithm you can give to your patients, and then they can self-titrate. You can motivate them, and subsequently you can introduce them more complex algorithms for self-titration. Now coming to the intensification. Another advantage of basal insulin is that you can intensify in a number of ways. In premix insulin, you are starting with 2 pricks, or you are starting with 1 prick, go to 2 pricks, go to 3 pricks, and then there is a basal bolus insulin therapy. But with basal insulin, there are various options. First is basal plus. You can add only 1 prick of bolus insulin, or you can shift your patient from basal to a co-formulation 1 prick, because co-formulation will also contain rapid-acting insulin analog. So it is like a basal plus therapy. You can even add on GLP-1 analog on top of basal insulin for intensification. And then if required, you may shift to premix twice daily, or you may shift to basal bolus therapy. So those are a range of options are available, and you can very well individualize therapy depending on various factors in patients who are on only basal insulin therapy and they are not able to reach their target HbA1c. So these are the various strategies. Basal bolus has got very good efficacy. Flexibility is very good, but convenience is very less. And there is a lot of risk of hypoglycemia and weight gain. Requires a lot of monitoring. Basal plus is non-inferior to basal bolus, particularly when it is initiated early. It has got good flexibility, good convenience, and hypoglycemia and weight gain are less as compared to basal bolus or twice daily premix. Twice daily premix is inferior to basal bolus when initiated late. In early, there are no good studies to compare premix with basal bolus in the initial stages when type 2 diabetes patients they are failing on oral anti-diabetic agents. Flexibility is less, convenience is good, it requires a lot of monitoring, more than basal plus but less than basal bolus, and the risk of hypoglycemia and weight gain, I think it is highest with premix, then comes basal bolus, and then comes basal plus. Insulin co-formulation is a good way if you want to start a single prick, and later on you may intensify with variety of options in insulin co-formulation also. That it is inferior to basal bolus when initiated late. Early data are still, there is not a lot of evidence, but there is good amount of evidence to suggest that co-formulation instead of a basal bolus is another option. 2 injections, so good convenience, flexibility is not there, needs monitoring, and the hypoglycemia weight gain, they are less as compared to premix, but almost equivalent to basal bolus or better than basal bolus therapy. And basal and GLP-1 is a very good combination because that will be targeting to different pathophysiological effects, and it will be having a very good convenience, flexibility, and less chances of hypoglycemia and weight gain. But one should keep in mind that whenever you are thinking of intensification of therapy, cost of therapy also is an important factor, and one should keep that in mind. So now when you are transitioning from one regime to another, like patient is on one basal, now you are shifting them to twice daily premix, then divide total daily dose in half, give pre-breakfast and pre-supper premix insulin. Ideally 24 hours should be lapsed between last basal dose and the beginning of premix, but generally this is being converted when the sugars are not well controlled. So you may even start within 10 to 12 hours premix insulin after giving the last basal dose, and then titrate according to self-monitoring of blood glucose. And if there is a recurrent hypoglycemia, you may reduce the dose by 10 to 20%. If the patient is already on twice daily premix and now you are shifting them to a once daily basal therapy, then 80% of the total daily intermediate acting component in the premix insulin. So suppose the patient is on 40 units of premix insulin daily. So the intermediate acting component will be 28 units because it is 70%. And then 80% of that 28 units should be the new basal dose, which is to be started. And then depending on SMBG data, you have to titrate the basal insulin therapy. Suppose the patient is on twice premix and now you are shifting them to basal plus. So you may start with the same basal dose as I have told you, and you may start with a small dose of bolus insulin with major meal, and then you may titrate according to self-monitoring of blood glucose. Now suppose the patient is on premix insulin and now you are shifting them to a basal bolus insulin therapy, then you have to calculate the total daily dose. 80% of the total daily dose, 50% will be basal and 50% will be bolus, and that bolus generally it is being divided in 3 equal doses, or it is being divided 1/4 and then rest in half, 50% doses before lunch, before dinner, and 1/4 dose, 25% dose, that is before breakfast. So depending on that you may start, and then depending on SMBG you need to titrate the dose and you need to reach the target value so that a good glycemic control is reached. So this is how you will shift from one kind of enzyme to another kind of enzyme, and what you should keep in consideration while shifting patients from one insulin regime to another insulin regime. Now, when twice daily insulin regime is being used, then you have to titrate the fasting, the pre-breakfast doses to be titrated depending on post-lunch and pre-dinner sugars, and same way pre-dinner dose is to be titrated depending on post-dinner blood sugar as well as fasting blood sugar. But whenever you are using premix human insulin, you have to keep in mind that the risk of nocturnal hypoglycemia is high and the patient may require monitoring at 3 a.m. When you are using a premix, insulin analog, then the risk of that nocturnal hypoglycemia will be less as compared to the regular human insulin, but still it is there. So the patients will require 3 a.m. blood sugar monitoring almost every week or every 15 days. And this is the suggestions or guidelines by RSSDI as far as premix insulin therapy and how to intensify with premix insulin therapy is concerned. You may start with once daily, go on to twice daily, and then you may go on to thrice daily. Thrice daily is there only if you are using premix insulin analog. If it is a premix regular human insulin, then it is only twice daily. Thrice daily you may not use, but with insulin analog, there is evidence to support that one may give a 3 pricks daily to reach the target HbA1c if it is required. So the key message is early insulin initiation or timely insulin initiation is very much important. The delay in treatment intensification with insulin will result in poor glycemic control, bad glycemic legacy, and that will result in a lot of complications later on. Basal insulin is the way to start insulin therapy in type 2 diabetic patients. One may start 10 units or one may start depending on the HbA1c level and weight of the patient. Titration is a key to reach the target fasting plasma glucose and the target HbA1c. You will be able to reach that in almost 50 to 60% of patients with optimal oral anti-diabetic agents and very well titrated basal insulin therapy. And if required, one may intensify basal insulin with either 1 prick of bolus or 1 prick of GLP-1 analog, or straightway go to basal bolus therapy, or shift to twice daily premix insulin therapy, or even shift to 1 prick of co-formulation. That will also give you a lot of scope for intensification also. With that, I end my talk. Thank you very much again, Dr. Bansi and the entire DIAK team for making me part of this iSchool.
Thank you, sir, for your insightful talk. We'll now like to invite, we have some questions, sir, but we'll ask at the end of the session. If
Yes.
that is fine. Yes, sir. We'll now invite Dr. Jimit. He has fellowship in endocrinology, diabetes and metabolism, Mumbai, consultant endocrine diabetes and metabolic physician at Surat, co-author for RSSDI guidelines for inpatient management of hyperglycemia, executive director, RSSDI textbook of diabetes, 2019 Rising Star Award for Indian Academy of Diabetes, TYSA National Award winner, member of American Association of Clinical Endocrinologists, former assistant professor of medicine, multiple research publications with more than 10 chapters in a book.
Thank you, Dr. Vyas, for the kind introduction. And let me thank Dr. Bansi sir and the whole team and Sanofi for inviting me for this wonderful insulin school program that we are running from last few years. And I thank again for making me part of that. Today, I hope my slides are visible now.
Yes, sir.
Yeah. So today I'm going to talk about the insulin storage, motivation, myths and facts. So we'll be discussing so many things in these 2 days of insulin and insulin initiation, motivation, treatment. Very important part of this insulin management still remains, and very commonly mistaken part still remains about storage. Very basic issue, but very important issue about storage is very important thing. So insulin products should be stored at around 2 to 8 degrees Celsius. These are the non-open vials and cartridges that should be stored at 2 to 8 degrees Celsius. This is very important. We know insulin is a complex structure, it is a complex protein, and it is very heat sensitive and photosensitive molecule. So very important thing is we need to keep it as a specific temperature, otherwise it will degrade, it will lose its complex structure, and that's where it loses its efficacy. And very important thing is we don't have actually any measure to understand or to judge that this insulin is effective or non-effective. So what happens if the insulin is degraded or become non-effective? There is no other way that we can judge it from the insulin itself, we can see itself, but we just take an assumption from its reduced efficacy when injecting into our patients and rising sugar level. So this is very important. We don't have any measure to actually see the efficacy even without injecting insulin. So remember, temperature and storage is very critical aspect, and all insulin products should be stored at 2 to 8 degrees Celsius. Very important thing is we should never freeze them. If the insulin is frozen or it is kept below 0 degrees Celsius, and it causes cracking of the vials and cartridges also, and also the efficacy of insulin is completely lost and we should throw it. And we should never inject an insulin that is frozen. So this is very important to maintain this narrow range of 2 to 8 degrees Celsius. And all these factors can cause the product to become inhomogeneous and non-sterile also. Keep the insulin cartridges and pens that are currently in use at room temperature below 30 degrees. So you can keep them in a room temperature that is ideal, that is less than 30. But remember, this is very much feasible for the Western countries, which are cold countries. But in India, frequently the temperature rises above 30. So this becomes a very important thing. And many of the times it is practical to keep them in the refrigerator in the same degree cells, same temperature of 2 to 8 degrees. But we should keep it or bring it up to the room temperature before injecting. What about transportation? Again, very important thing. The risk of freezing insulin products must be minimized during transportation. Many of the patients, they transport insulin along with ice. And sometimes what happens when insulin is stored in an insulated bag or cooled thermoflask with ice, if the ambient temperature is expected to be higher than 30, this ice or cool temperature, if the insulin is in direct contact, they will again become frozen. So remember, it is very important to maintain the temperature in the critical range. Insulin should not be kept in a locked car with closed windows, because in the car, if the car is under the sunlight, the temperature may shoot up, be above 30 degrees very frequently, and in India up to 40 degrees also. And while traveling by air, okay, insulin should not be placed in the checked-in baggage, because there is huge temperature fluctuation with your baggage. So always ask your patient to keep the insulin with the hand baggage itself. That will help them maintain the temperature level. And mostly the checked-in baggage, many of the times they freeze, because when the flights are at the very high altitude, many of the times there is freezing temperature. So this is very important thing. And insulin should be stored at 8 degrees Celsius. The insulin in use, which is currently as used, like vials and pens, should be kept at a room temperature below 30 degrees. And it can be there for up to 28 days if it is in use. But the non-used vials and all those things should be at the 2 to 8 degrees Celsius. There are a few do's and don'ts. Store the products in the refrigerator. Do not store in freezer. Do not store products near cooling agents. Do not keep the refrigerator open for a longer time. And refrigerator should be kept plugged in for 24/7. Many of the offices or some of the medical stores also, when they go out in the night, they switch off the refrigerator switch and the temperature increases. So that stored insulin temperature is not maintained below, will be between 2 to 8. And always there should be a power backup to maintain and ensure the product storage temperature. And common issues are refrigerators are many times overloaded. Refrigerators are switching off after office hours, very, very common thing. And products are exposed to external environment. And suppose insulin is placed here at the end of the refrigerator or door, and commonly it is exposed to the high temperature, and when it is frequently opened, and products are stored in freezer or without coolant. Sometimes insulin is frozen, and that you should throw away and should not be used. So simple few of the other comments. Humidity, there is no special requirement. Very high humid environment near the sea also you can keep it. Insulin should be protected from direct sunlight. Insulin should not become wet, such as rain, sleet, or snow, and because many of the times it get infected. Orientation, we follow the arrows or any other marks that are indicated for the current orientation for the vials, and never sand or keep insulin product together with dry ice, because of the falling of temperature below 0 degree, and insulin may freeze and we lose its efficacy. So very important thing about storing insulin is the attaching needle and then keep it in storage. So very, very common mistake practically we see everywhere where needles are reused. We know needles are costly in India as compared to other. It costs now 12 to 15 rupees for a needle that is single use. So many of the patients, they reuse the needles. And the issue comes in the storage also. What happens? Patients leave the needle attached to the pen. And what happens when the temperature is cold, the air bubbles in the cartridge, they are formed. Why? Because when the temperature of the insulin reduces, its volume reduces. And then air can come inside here and bubbles will form. Similarly, what will happen when a cartridge is little bit warmer or hot? What will happen? The volume of this insulin increases and there will be leakage of the insulin out. So, well, always remember, do not keep the needle attached to the pen. Also, leaking of the premix insulin. We India, we use many of the times premix insulin. And what happens if you use this premix insulins and you keep the needle attached? So there are two different solutions inside this premix insulin. And what will happen? That one insulin may leak, other will not leak. And there is change in the ratio of the two insulins, like rapid acting or intermediate acting insulin. So this will give you incorrect mixture and incorrect doses. So it is very important to continue to consider all these steps. Coming to very important thing of myths and motivation. 2 days we will be discussing here that our patient needs insulin, our patient needs to be started on insulin, they need to monitor them, they need to adjust the doses of the insulin, and they need to get the wonderful glycemic control. But the thing is, patients, they don't start insulin because there are lots and lots of myths about insulin initiation in them. And motivation is also a very important thing. So myths and facts we need to rule out. That we will be discussing those myths and we'll be discussing some of the easier way that this myth can be avoided, the patient's inertia can be avoided, and many of the times there are inertia factors in our clinicians' minds also. We doctors are also many of the times hesitated to start insulin. So we need to discuss these myths, facts, and how we can motivate our patient. Very important thing, and this is one of the important steps for success of your insulin therapy. If you don't start and don't motivate your patient properly, patient is going to stop insulin in between, and you are going to lose the patients, or you will not be getting a good glycemic control if you don't start it and don't motivate your patient and don't educate your patient properly. So this is the extreme important step. So commonly what happens that there are many of the myths in our physicians' mind also and the patient's mind also. So what are the important things for physicians, myths and barriers? Or these are the factors that increases the inertia. So we also need to be clear about this. So lack of appropriate education in the physicians. So that's why we are here. So this is the first and foremost. If you learn how to give, how to take care, how to monitor, how to adjust, and how to motivate your patients, that's why we are come here for this wonderful iSchool program. So lack of appropriate education is the foremost thing. I'm sure after these 2 days of extensive teaching about insulin, you'll be excellent at starting and adjusting the insulin doses and getting good glycemic control from your patients. So appropriate education for the doctors is the first and foremost thing. We also are afraid about excessive weight gain, but simply we have so many measures we can remove, or we can minimize the weight gain. There are so many weight loss treatment now available along with insulin in India that has cost effective also now. Complex regimens are also there. So it's always in our mind that patient will be very unhappy with these complex regimens, but we can simplify that. We will see also that there are risks in patients with comorbidities. We feel that patients is already having CKD, he will go into hypoglycemia. Also, we can sometimes associate it with complications onset also. Similar for patients, we also see. And patients' perception of insulin treatment and outcomes, we know that patient is not going to understand, and we don't have time. And we are also sometimes worried about hypoglycemia. We are also sometimes worried about impaired quality of life of patients. And always there is a mind that there is lack of patient adherence to the treatment. If I start insulin, I will lose the patient. This is the first and foremost thing. And sometimes we are also worried about the financial restrictions about starting newer insulins. This is all our mind. But remember, all this can be very simply. There are always alternative available there. And if you have some time, and if you educate your patient properly, you can overcome all these barriers. What about patients? There are also patients' myths about insulin initiation. Many insulin initiation myths are there. And you can see this is one of the survey which showed attitudes among patients who are willing or unwilling to accept insulin therapy. Both in unwilling or willing type, the factors were similar, okay, or the myths were similar, what we can see. So we all know patients have myth there. સાહેબ એકવાર ચાલુ કરશું પછી ક્યારે બંધ નહીં થઈ શકે. So patients have always a perception that they can never stop the insulin. But remember, insulin is needed when it is needed. Usually there is no endogenous insulin production is almost minimal or nil when we are starting insulin. Many of the times you can tell your patient that it is the need, they need to continue it. Sometimes for severe hyperglycemia with osmotic symptoms, or when we want for surgery, or when for temporary use or for pregnancy, definitely we can assure our patients that if you start insulin on time when it is required, there is higher chances that you will be able to stop insulin. Okay, so always counsel your patient, then they will be able to understand. Patients care not good enough. They are saying that they are not taking patients good care. No, sometimes they feel that insulin, they may not be feel confident with the therapy, but remember, newer insulins are there. With the proper education, they will be having a normal lifestyle, a confident lifestyle with the treatment. They always correlate insulin treatment with low sugar attacks. Hypoglycemia, they are always worried that sahib maru sugar low thai jase adhi ratre mane sugar. They are always worried. So remember, always good education, good diet, good lifestyle management, and use of newer insulins that can remove this problem from at all. So this is very important thing. And there is always anticipation in the patient's mind that insulin is painful injection. We have been taught from our childhood कि बेटा ये खाना खा लो, ये गोली ले लो, नहीं तो डॉक्टर इंजेक्शन लगा देगा. So our mind is always been trained from our childhood that injections are painful, and whenever you say about insulin, patient correlates with the injection technique. But remember, if you counsel your patient and you show them the needle, so that see, this is the 32 gauge Teflon coated needle, and if you put it, you even feel the pain. Don't worry about the pain. You can't even feel the thing that some injection is going on, and that's where the first injection you must give your patient into your OPD in front of you. This is where you can relieve this anticipation or relieve this anxiety of pain. And once your patient takes this injection in your clinic, they will forget about this pain, because then it will be very easy. Then patients sometimes say the life will be restricted, but we now have wonderful insulin molecules available, which can be taken care that patient can live active lifestyle once daily, twice daily. There are different regimens are available right now, a combination with oral drugs that are available right now. And with that, life is not restricted at all. Even with the newer basal generation insulin, we have now, we can now have liberty to give the injection few hours prior or later to the fixed time. So this is very important thing. You can explain your patient, you can change the regimen of your insulin treatment, you can make your patient's life more free and more active also. And sometimes patients have myth that my diabetes will be more serious if I start insulin, but this is absolutely not correct. We have to correlate that if you don't start insulin at present, then you will have complications of diabetes. And if you start insulin properly and you control it very well, you will be able to get a good complication-free life. Your life will be good and without any serious. And sometimes what happens, patient correlates with the insulin treatment with the complications like blindness. So commonly what had happened in India, the trend is like that patients, they delay insulin unless they have some complications. And one of the common thing that has been associated is retinopathy. When the retinopathy retinal specialist or the ophthalmologist says, insulin chalu karo, sugar control karo, nahi to aankh chali jayegi. And that point of time, majority of insulin initiation were done, I am telling about few years back. And that's why the patient's mind, there is now a misconception that insulin चालू करो और साथ में आंखें चली जाती है, रोशनी चली जाती है. This is not the same thing, because there was no good sugar control that has led to the microvascular complications. This is very important thing. Another very important thing, this study was done that about perception of insulin therapy among treatment naive patients who have never taken insulin and experienced patients, what were their expectations. So very interesting observation study that they have compared two kind of patients, and they have seen who are taking insulin very long and who are taking insulin first time, and their perception of insulin treatment has been changed. Okay, so you can see the two graphs here. The blue graph is the who have never taken the insulin, and they are seeing that they are, if they take insulin, they feel that they are very sick and हम बीमार हो गए हैं, हमारे को ये हो गया है, हमको कोई बड़ी बीमारी होगी और इंजेक्शन चालू हो गया. But once they are taking insulin, their experience, they're feeling more better and they don't see them as more sick. Very important thing. Okay. Similarly, what happens? Injection fear is very, very high for first time insulin takers, but it almost goes away with experience. So this is where you want to give your patient first injection in your cabin in front of you. This will make a huge impact. Okay. Very important, patient sees that it is less flexibility, but once they have experienced, the flexibility improves, they can live more active life. Patient sees whenever they are starting insulin, they never taken insulin. Insulin makes diabetes worse, but it improves drastically once your patient has improvement. Very interesting thing was the observed in this patient is the insulin treatment was correlated with weight gain. Okay. Initially, they don't have any issue about weight gain because they were mostly losing weight because they were having hyperglycemia and losing weight. But with the experience, who are taking insulin for a long time, their only concern was weight gain. So this is very important and very interesting observation done in this study. So I just kept this to make you more familiar that how patients' perception changes once they start insulin. This is very important. What are the common causes of non-adherence? We want to motivate patient to not skip insulin. So multiple and complex regimens are there. Very, very important. If you start your patient with directly basal bolus therapy in type 2 diabetes, though for type 1, we know basal bolus is still gold standard. We don't want to do anything else. But for type 2 diabetes, if you start with the basal bolus treatment, 4 injections per day, they will going to be missing it. But you can simply minimize the or simplify the regimen by starting with basal insulin. For fear of weight gain, definitely what you can do, you can just change the diet, you exercise, you reduce the other doses like sulfonylurea or pioglitazone when starting with insulin. That can help you minimize weight gain. And diet and exercise and the appropriate insulin dosing will definitely prevent hypoglycemia and prevent weight gain. So that is the part of the work team of dietitian also, diabetic educator also, and you also for fixing the dose. So adequate titration of the doses will prevent hypoglycemia and weight gain. Poor and infrequent communication with healthcare professional. Yes, we need to give time. We need to adjust the doses, and it is very important. Cost. India is one of the very we are in a very I would say we have been blessed to be in India with this so good pharma industry in here that cost has now cost has been so wonderfully managed in India that we can have a very cheaper insulin and one of the best quality and latest insulin at an affordable cost also. And we should also explain that cost of current insulin therapy is nothing as compared to cost of complications that if you don't take insulin treatment and don't control your blood sugar level. So you need to explain this also. And there is perceived lack of efficacy. Very important thing is when we want to simplify the medication. Now come as a lack of time there, let me go for the important studies. So we have seen so many doctors or patients coming from those doctors, they have been said that or they have been threatened to start insulin, otherwise they will be having complication. Very important thing. So threatening or fear of complications is always gives a negative impact to a patient over a long period of time. So never use this, in my point of view, And what you can do, you can positively give them this fear of complication as an advantage to you. So always you will going to say, see your HbA1c this high, you will have your kidney complication, eye complication, you will have a heart attack if you don't control your blood sugar level. But remember, the correct way will be, you can show them the science and research that has shown that if you control your blood sugar level properly, even 1% change in HbA1c will reduce, okay, your any diabetes related complication, you reduce your death by 70%, all cause mortality, microinfarction by 15%, stroke by this, peripheral vascular disease by this percent, or microvascular disease by 24%. So if you tell them positively, okay, so that you can say guarded use of this fear of complication, that you can prevent this complication if you do this, and don't use this blindly, and don't use the word that insulin chalu karo nahi to kidney fail ho jayegi. So always use this a good language and use this positive message. And one of the times non-adherence part we have seen. So always go systematically for the complex regimen. Start with the basal insulin. Okay, but always remember, whenever patient comes to your first time, discuss the insulin treatment from starting discussion only. This patient should be prepared for insulin treatment at your first visit, explaining how to start and titrate insulin. Ongoing educational support is very important thing, and later on monitoring and adjusting the therapy is very important thing. So from first time to later on, then you can actually gradually add on the insulins also, basal plus and basal in bolus is also later on. But remember, start with simple insulin, then up titrate. As the beta cell deterioration progresses, there is more need of insulin for prandial insulin also. Add just at first prandial insulin to basal one, and later on you can add a full-fledged basal bolus insulin. Last part, as I already mentioned this, that first injection should be given in your OPD in front of you, and how to take insulin. If you do this, the fear of pain, fear of needle is gone immediately, and they will feel very happy when they feel no pain in front of you. Very important thing, the insulin device is also matter in this is my personal view, that is, it is always better to start with the lesser complicated and simple devices with simple or painless methods. So always, in my point of view, it is better to start with the simple disposable pen and a very fine needles that will be painless, very easy to use, and patient will have tremendous confidence in you on insulin treatment, and they will feel it very, very easy. So I thank you everyone. I hope I am cleared in time, and if any questions are there, I'm happy to share.
Thank you, sir. That was very clinically relevant talk, much needed. Thank you.
Thank you. Thank you.
Dr. Dhruvi, do we conduct the question and answer session?
Yes, dear. There are, I think, 2 questions. One is a comment and another is a question. Tarjani, would you like to read the question?
At what HbA1c level in new patient should we go for insulin therapy? Pratap sir, will you like to answer that?
Hello. Yes, can you repeat the question?
At what HbA1c level in new patient should go for insulin therapy?
I think not only HbA1c level, but the patient's symptoms, they also matter a most. If the patient is having a symptomatic for hyperglycemia, having catabolic symptoms suggesting excessive urination, weight loss, and catabolic features, then it is better to start with insulin, whatever the HbA1c level it is. But generally, dictum is when the HbA1c level is more than 10, I think it is better to think of insulin as a initial therapy. If the patient is willing, try to convince. But if there are circumstances, patient is asymptomatic and not having any symptoms, HbA1c is more than 10, and patient is not willing for insulin, you may give them oral drugs, but then you need to have a very close follow-up to see whether the patients, they are responding to oral drugs or not. So better idea is to put them on a 1 peak of insulin with oral drugs to have a good glycemic control, and insulin will also take care of glucotoxicity, and that will also help in improving the beta cell function and persistence of beta cell function.
Thank you, Pratap sir. It was quite clear from the talk of all the faculties in our first session that, you know, there are so many different kinds of insulin. We talk about basal insulin initiation. Jeethwani sir is actually teaching us how to titrate and how to intensify it. So we have a huge number of attendees today, almost 51 right now. And I would request any one of them, if they have any questions, to please put it up in the chat box. In the meantime, maybe I can put up a question to our panelists today. With the co-formulation as one of the initiator molecule, the IDEG as part, what are your opinion, or what is your critic about initiating a co-formulation versus initiating a basal insulin as an initiator insulin?
Thank you, Dr. Dhruvi. I will give my opinion, and then I will request Jimit and Pratap sir to give their opinion also. But the problem with the co-formulation with this longer acting component and the shorter acting component is that sometimes you are able to reach the fasting glucose. You are able to control that with some titration, but still the prandial remains a problem. At that time, now you are in a fix. You cannot increase the dose because again that can lead to hypoglycemia in the fasting state. But the prandial still remains a problem. So there is this is one of the limitation which I find with this co-formulation. It doesn't happen with Nph because Nph the duration of action is short, so you can easily go for the up titration. But again, we know that the co-formulation of the Nph also causes more risk of hypoglycemia in the postprandial phase. So these are the limitations which I encounter, and I can have the opinion of Dr. Jamit as well as Dr.
Yes, Dr. Amit perfectly said. So limitation comes when we want to up titrate it. So it's a main issue here. I use some of my patients who take a big meal, who are in the textile market industries here. They want to leave their home at around 10 or 11, and they return at very late at time. So for those kind of patients, few of them who have, even after a lot of counseling, they are not able to change their diet, and those patients I frequently use this co-formulation. Otherwise, up titrating is very, very difficult, as you said.
I personally feel that co-formulation is a good way of intensifying from basal to basal plus, one peak and one type of insulin, one peak, and that will give you some postprandial component also for coverage of postprandial blood sugar. But to begin with, I still stick to basal insulin because it is very easy to titrate, very easy to reach fasting plasma glucose in that narrow range. And then if required, you may go on if the patient's postprandial are not good control, because now we have got a lot of oral agents which are there, which are complementary to each other. And with various combinations, you will be able to bring postprandial down also on top of basal insulin therapy. So I think co-formulation, generally, I do not start with co-formulation. I generally start with basal insulin. During journey, one may think of shifting to one peak of co-formulation if patient is not very much keen on taking two different kinds of insulins, two peaks. Then one may think of this. This is one approach. And second category of patients who are having, like Jimit said, people who are having fixed job schedule like bank and other people who are having 9 to 5 schedule. They take brunch at 9 o'clock, they return at 5 p.m. and they take dinner at 8 p.m. I think for those category of patients, you may give co-formulation, one prick at the morning and a very small prick at dinner to cover the post-dinner and to maintain 24-hour sugars in range. Or even one may use rapid-acting insulin analog before dinner to cover post-dinner sugar also. But titration will be difficult because there is a fixed ratio of rapid-acting analog and a basal analog. So you will not be able to titrate both separately. Whatever you do, both doses will either increase or decrease.
Thank you, sir. We have quite a lot of questions in the chat box. Dr. Kamudi, Dr. Tarjani, do you want to take up those questions? We have our panelists, giving their precious time today, so it's
Yes, ma'am. Yes, ma'am. We'll take over. So the next question is, what's the maximum dose of premix that we can use? Sir, I think Pratap sir would like to. Sir, could you answer this for us? So you're not audible.
I think any kind of insulin, there is no dose limit as far as insulin is concerned. But once you are using insulin and you are giving insulin in a dose of, say, 1.4 to 1.5 units per kg body weight, and you are going beyond that much units, then you have to first check the insulin injection technique and the storage of insulin, because these are two important issues. Many of the people, they are not taking insulin properly. Either they are injecting in lipohypertrophy areas, and there is a erratic absorption. So whenever very high insulin requirements are there, you have to check their injection site, you have to check their injection techniques, you have to check how they are storing this insulin, because these are the issues which will result in reduced efficacy of insulin, and patients may require very high doses of insulin. Otherwise, there is no dose limit as far as insulin dose is concerned or units are concerned. You may go beyond any point of time to provide good glycemic control. But maximum, generally, in clinical practice, if we see, it is 1.2, maximum 1.4 units per kg body weight.
Yes. Thank you, sir. So there's one more question, but on the opposite side of it, that can patient discontinue insulin under supervision if patient is having lifestyle control? Like one was, what's the maximum limit that can be given, and the other one is, when can we stop it?
So as I said, so there is always a consideration in patient mind that ye band hoga ki nahi. So if it is started when your beta cells are already depleted and at very late, then definitely there is only a thing that you need to continue for lifelong. If the patient endogenous insulin production is zero now, okay, so that way it cannot be stopped. Otherwise, the other symptoms will start and complications are coming to be early. And sometimes, ketosis can be also there if when the endogenous beta cell are already lost and no endogenous insulin is produced. But if you start properly, as I said in my talk, as start early when it is very well requirement, temporary, for example, before surgery or during pregnancy, definitely you can stop it. And sometimes we start early at the time of diagnosis also, as Dr. Jetwani sir said. And then definitely we can assure our patients that, see, you have family history, you are obese, type 2 diabetes, and at your patient, the fasting is 300, you start it. We are starting tablets also. And once you have good sugar control, we will gradually reduce and stop the insulin. Definitely in those cases, with confirmed type 2 diagnosis, we can definitely assure a patient that it will be reduced and stop later.
I would like to add one thing to that, Doctor. What happens is that if a patient comes to us early in the phase and is having hyperglycemia, then there are chances that there may be a greater component of the glucotoxicity, and the beta cell mass still may be, some part of the beta cells may still be functioning. So in such patients, if you remove the glucotoxicity element by giving the insulin early, then these are the group of patients in which you may find that they are easier to take off the insulin. But if somebody is having a long-standing diabetes and it is not the glucotoxicity alone, it is also the beta cell depletion also, then I don't think we can take these patients off insulin anytime.
I will add one point only. Insulin withdrawal should also be a stepwise process. It is not that the patient is on 20 units of premix or 20 units of basal insulin and you straightway stop it and put them on a lifestyle modification. You require a lot of monitoring, even if you are subjecting them to a rigorous lifestyle modification or you are modifying their oral anti-diabetic agents. And depending on that self-monitoring of blood sugar charts, or even if required, you may put them on a continuous glucose monitoring devices like AGP. And then depending on that, you may modify the dose. And if circumstances prevail and if the conditions are favorable, patient is responding to oral therapies or lifestyle modification, one may reduce the dose of insulin and even may stop it. But this should be a gradual process. It should not be straightway putting off insulin and putting them on a rigorous lifestyle or oral drugs.
Yes. Yes. So we have one case scenario. If a patient is having 300 FBS and 500 postprandial and the HbA1c is 9, then can we start the patient on glargine? Like, I think the question is more like, is this an indication for glargine, a long-acting insulin?
Yes, perfectly. We can start. Basal insulins are the recommended insulin to start initially. Fasting is very high. Any fasting more than 250, ideally, it's a ketogenic potential. So insulin is recommended. Second thing, if you bring down the fasting first, definitely you'll be able to reduce the PP alongside. We have so many papers available with that. So fix fasting first, and later on, if required, we can switch on to basal plus or sometimes premix, depending upon the patient. So yes, glargine is an option initial, and guideline-wise, it is the first recommended option.
So like we would like to start only glargine first, and then only if required, we'll put this patient on bolus doses.
Glargine plus OADs, then it will mostly it will suffice. If it is newly diagnosed, not on any medications, then definitely it will suffice. And later on, if it is newly diagnosed, insulin we may knock out later on.
Okay. Yes, sir. Thank you. Then we have that fasting is only 90 and postprandial is 250, HbA1c is 10. Which insulin to start?
The patient is already not on insulin and the fasting is under control and it is a prandial.
I personally feel if HbA1c is 10 and fasting will not be 90, that is what the general dictum is. Only postprandial of 250, fasting 90 will not contribute to HbA1c of 10. So the HbA1c will not be that high. If HbA1c is more than 9, generally fasting is more than 150. And the patients, they generally require therapies which target both fasting and postprandial. So mostly this is a very hypothetical scenario, which I think probably will not exist in clinical practice. But if HbA1c is 10, fasting is 150, postprandial is 350 or 400, I think you need to have a therapy which will target both the components, both fasting and postprandial.
Partha, there is a possibility patients with a chronic liver disease and patients with a chronic CKD patients and steroid-induced hyperglycemia.
Yes, sir.
You may have a patient with a fasting which may be normal and post-meal is very high. If I have a patient with a fasting normal with post-meal very high with very high A1C, I would like to investigate the patient for a chronic liver disease, for CKD, for a patient with steroid-induced hyperglycemia, and even so these are the conditions which increases only the prandial sugar level high. And these are the patients to be treated with a rapid-acting insulin analog. So mostly even in the GDM patient also, we have seen that patient with a HbA1c of 9, many times doctors start to treat them by premix insulin, which is not the ideal way of treating a GDM patient because it's a prandial sugar which is high. It's better to start these patients with basal bolus therapy, start with a low dose of basal and more of bolus dose which is required. As you rightly said, that patient will have a 10 A1C which will have fasting and post-meal both high, where you have to target both the things together. But one thing which Kamudi I can tell that the fasting is relatively normal, which let us understand less than 130, and post-meal is around 250 or 200. Let us assume this case, and with a A1C of around 8.5 or 9. Should we start these patients only on basal insulin, which is that insulin initiation, what has been, ADA guideline which they are talking. So India is a condition where the post-meal glucose level is very high. And that's the reason India is also a country of premix insulin initiation is more popular in our country. But still, I don't agree with the premix because still 70% of that is still again going to take care of your fasting and chances of getting your hypo are very high. So I would like to treat these patients with 8.5 or 8 A1C or 9 with medication which is prandially regulating. So, trying to control this patient with nutrition counseling, with alpha glucosidase inhibitor, with GLP-1 analog, which will be primarily target the post-meal glucose level, and you may achieve even without insulin also. But is possibility is there, the fasting is less than 130 and post-meal is only high, then it's the prandial insulin or rapid acting insulin analog, which I would like to control these patients with post-meal. With the advent of continuous glucose monitoring, which we are using in our clinical practice so often, with a patient with an uncontrolled A1C and with their fasting and post-meal, the reports is not coinciding with the A1C level, then I may go with these patients on a continuous glucose monitoring, seeing their glucose profile, and accordingly I will, tailor-made therapy we will have to make for these patients. Jimit and Pratap, you may continue. I'm sorry, in between.
No.
Yes, sir. So now we have one more case that regarding tapering of insulin. If initial HbA1c was 15, but it has come down to 9, can we stop insulin and the patient is feeling better? That is what the question says. And can we stop insulin and switch it to OHS?
So I would like to add that if it is still 9, then it is still very high. Okay, so there is at present, I would say it is no need to stop insulin. What is important thing is the add-on the OHS if the patient is having type 2 diabetes, and later on gradually down titrate the dose of insulin as Dr. Jethwani sir told. And 9 is still high. Mostly what will happen if you add 2 or 3 OADs, then it will take care of the at least 3 mg% of the HbA1c and you can bring it down. So add OAD, gradually down titrate the dose of insulin from the basal bolus, you can come down to basal only, and later on, if it is well controlled, then you may remove insulin. Otherwise, 9 HbA1c is still very high, and in my point of view, depending upon the patient profile, he will require long-term insulin.
Thank you, sir. There is one last question we'll address. Premix insulin 30/70 twice daily, but before breakfast readings are very high. Can we advise it to take 1 hour early as the peak of the short acting occurs after 1 hour? I think the question is when to take what is the correct time to take the premix insulin before the meals?
So let me answer. If the question is about pre-breakfast or post-breakfast, it is not clear. So let me answer both. If the pre-breakfast readings are very high, then ideally you should increase the dose of nighttime premix insulin. So night insulin you should increase. That will take care of the pre-breakfast sugar level. If the post-breakfast sugar level is high, and you can titrate the morning dose. Ideally, if it is regular human premix insulin, it should be taken at least 30 minutes prior to the breakfast. If it is premix analog insulin, that also it should be taken at least 15 minutes before the breakfast. So if the post breakfast is coming high, one thing you can do is increase the premix 30/70 dose. Still your post breakfast is coming high, but your post lunch or pre-dinner sugars are going very low after increasing morning breakfast. You can change to 50/50 premix insulin. That will take care of the breakfast surge only and will not cause hypoglycemia post lunch or post dinner.
I think
yes, sir.
Breakfast is high. One may shift from regular premix insulin to premix insulin analog, because that will be having a better postprandial glycemic control. So that is one option. And as Jimmy has already highlighted, and if nothing is able to control that high post breakfast values with normal post lunch or low pre-dinner values, then it is time to shift patient to a basal bolus insulin.
Yes, personally also we have observed a lot of fluctuations in patients who are on these premix insulins. The chance of hypoglycemia also increases a lot in these. Sir, we are done with the questions. I think we can end our session here and then come back again for the second session. Thank you so much, all the speakers.
Thank you.
Over to you, Dhruvi ma'am.
Thank you, dear. Thank you so much. Thank you, Pratap sir, Amit sir, Rakesh sir, Jimit sir. It was indeed a wonderful first session. Thank you again for being a part of our insulin school, and it is our school altogether. Thank you for a wonderful discussion and enlightening us with all the answers to the questions from the delegates. Thank you, sir.
Thank you. Thank you.
Thank you, Dr. Dhruvi. Thank you. Thank you. Bye,
Yes,
everyone.
Thank you. Bye, everyone.
For all the delegates, we'll be rejoining again in the evening at 7 p.m. I request you all to please take advantage of our evening session for the iSchool. We'll be talking about insulin pump and barriers to insulin therapy. Thank you so much.